Well, I'm delighted to talk on one of my favourite topics, and I hope to leave you with some enthusiasm that although problems can be hard, that doesn't mean they're insoluble, and we are trying to make some progress in this difficult area. But I'll start at the beginning about what is pain, and I initially put pain as a universal human experience, but actually it's not quite. You may know that there are some rare individuals who are born without the ability to feel pain. And you think, wouldn't that be a fantastic life? You would never, ever experience pain. You think, rich, fulfilling, fantastic life. And in fact, these people all die young because they're unable to protect themselves from injury. And that reminds us why pain is so embedded in us and in other animals. And that is that the ability to avoid harm and danger is essential for survival. But usually, when the danger has gone away or the thing that has injured us has settled down, that pain should settle down back to our normal activity. But sadly, in a too big a number of people, even once the injury has settled down, the pain may persist. And that pain does no good. It is not useful, it is maladaptive, and leads to impairment of quality of life and function. Now, despite it being almost a universal human experience, it actually was quite difficult for the scientists to define pain. And the International Association for the Study of Pain had to come up with this quite long definition, really. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or even described in terms of such. But it really has three key bits. There's the bit that you detect something's not right. I can call that the ouch bit. You realise that something is wrong. The next bit, it has to make you feel bad. It's not nice. I want to get away from this, and it motivates you to take some action to get away from it. That's the basic pain response. How common is pain? It's extremely common. 25 to 30% of our population suffers chronic pain, and unlike some of the other common diseases, heart disease or so forth, which largely have their incidence in late life, chronic pain is actually a young to middle-aged person's disease. So you look at the peak prevalence, and this is in Australia, this is from the MBF Foundation, the research arm from BUPA, and you can see the peak prevalence is actually in middle age. It's in the ages where people are trying to raise their families and try to hold down jobs. And so apart from the moral dimension of the suffering of chronic pain, there's a huge economic impact because people cannot fulfill their activities. The other thing to note is that in all these age groups, pain is more common in women than in men. I'll come back to this because it's one of the key themes of our research, is to try and understand why is this and what can we do about it. Now briefly I'll just go through some aspects of pain biology and some aspects of clinical pain. And this little diagram has a peripheral nerve, a section of the spinal cord here, and here's a brain. Now in the peripheral nerve we have some nerve fibres that detect things which are not bad for us. Here the little feather indicates light touch, stroking or sensation. And then we have other nerve fibres which detect danger, bad things. Now you might think all we need to do if you were designing a pain system is anything that stimulated that would be bad, and anything that stimulated that would be good. But it isn't quite so simple, and that's not the way the pain system has been designed. Both of these nerve fibres come into the spinal cord and they talk to one another. There is a communication system between these two. And once the result of that communication has occurred, signals do go up through the spinal cord and up to the brain. It goes to the parts of the brain that are associated with the detection of the signal. There are parts of the brain which then are associated with the emotional response to that signal. But if it stopped there, you'd still think, well, if I do this, you will get this kind of response. But there's another very important part of the pain system, and that is despite this upwards system, there's another system which controls the system from above. Other parts of the brain have descending fibres which then go into this communication system and can adjust it. It's like controlling the volume. It can amplify it or decrease it. So you don't have a static reporting system, you have a dynamic system which can be controlled and modulated. And clearly, pain scientists, we want to understand what are the factors that control increasing that volume so that we can try and look at what can we do to turn it down. Because in essence, a lot of chronic pain is associated with abnormal activity of this control system. To show you how pain detection isn't a simple, I do this to you, you feel this, here's just some observations. Battlefield commanders have known for centuries that soldiers can suffer horrific injuries on the battlefield and not notice it till afterwards. What happened? Why couldn't they feel it? We also know experimentally, one way we can give people less pain is by hurting them somewhere else. Not very good treatment, but experimentally we can see that the brain we can modulate that. Now, one of my PhD students is working on a project where we're tricking the brain into feeling pain to something that it should not be painful. I can't actually tell you any more about it because it would blow the cover for the experiment. But we're trying to see what insights we can get from that. And another clinical example in Queensland, where I used to work for a period of time, there's a marine poison you can get in fish, and it causes reverse temperature sensation. Hot water feels icy, and icy water feels hot. So pain, it's not a simple one-to-one correspondence. It can be highly modulated. And here are some puzzling pain conditions. Many of you will have heard of phantom limb pain. This is pain that can occur in a patient who's had an amputation, who may not have a leg at all, but they still not only feel the leg, but they can feel the pain in the leg, and they can feel it with exquisite spatial selectivity. They can say, between my big toe and the adjacent toe, there is an intense itch. On the toe next to it, there it's burning, but that leg isn't there. So for a long time, we didn't really understand how that could occur. Another puzzling pain condition is post-stroke pain. When the stroke affects a part of the brain known as the thalamus, it's a sort of a sensory gating area, and people with a stroke, they can get entire pain on half their body, a very difficult condition to treat. And another condition which has puzzled pain scientists and clinicians is goes by the name of complex regional pain syndrome. Of course, you know, in medicine, the longer the name, the less we understand about it, really, rule of thumb. And although it's not particularly easy to see, but this is the normal limb, and this is a limb of a patient. It's red, it's swollen, and I can tell you it's extremely painful. And this has often occurred after a minor injury to the limb or even a small injury to the nerve, and the patient may be left with years of extremely severe pain. With clear, obvious signs, there's the redness, you can touch it, it's hot to touch, but we still don't know why it's happening. Now, I mentioned that pain was initially a system that you think its useful function is to tell you about danger. But in my clinical practice managing headache, 99.99% of patients with headache don't have anything wrong with their head that indicates any tissue damage. There's still pain, but there's no tissue damage. And people often think, I think I must have something wrong with my brain or a brain tumor. You say, well, actually the brain can't feel pain. You can actually cut into the human brain, it doesn't feel any pain. So what's causing all that? That's complicated. What about back pain? As the introduction came, it's probably the single commonest reason why people seek medical attention. Yet we still don't know what causes it in most patients. And although we have very sophisticated imaging and scanning, there's a very poor correlation between what we see on the scans and the symptoms that the patients get. Another common condition is irritable bowel syndrome, one of the commonest conditions why people seek treatment for abdominal pain. There's nothing wrong with the gut, but it seems to be that the nerves in the bowel and in the spinal cord and brain are hypersensitive to pain from that part of the body. So it's really not a simple part. Pain is also cannot be seen out of the psychological context in which it occurs. The context of the pain has a major role on how people respond to it. A pain that would wake you up in the middle of the night and you don't know what's causing it will cause much more distress than the similar kind of sensory input if you know what's causing it and the fear isn't there. And expectation and previous experience are highly important. We've got to remember, we've all got the ability to learn, rats and us. We've learnt what's good for us, what's not good for us. And the experience we get is seen in the light of the previous experience, both good and bad. So one little corollaries is when your kid goes to have their injection or treatment and you think, what should I say? And you say, look, it will hurt, but be brave. And actually that's shown that it hurts more by telling that. Now, of course, you've got brownie points from being honest. They respect you being truthful, but actually you've hurt them more. If you said, I probably won't hurt very much, then they'll actually get less pain, although they might not sure always telling the truth. So I'm not saying you shouldn't tell them that, but actually the context determines the outcome. And this is absolutely key in treatment. In our pain management unit, we have I think almost as many psychologists as physicians, because it's not either or. We need to use both of those treatment modalities to get the best outcomes for our patients. Here are just a couple of examples from the literature. These are not ours. This is a widely quoted study. And this was looking at the effect of swearing on pain response. And took a very simple experiment where they took healthy volunteers and got them to put their arm in cold water. After a period of time, it hurts quite a lot, and it's a simple test. You just, with a stopwatch, see how long they can take it. And they did it on 2 occasions. Once when they were told they could just have a neutral word repeatedly, and the other time they could have an expletive of their choice given repeatedly. And they were able to do a much longer time in the experimental model when they could swear, as opposed to that. Now, I'm not suggesting we recommend this as a treatment. You can imagine the waiting room at the pain clinic would be a bit of a problem. But it gives an illustration of it's just not a simple turning on a switch. The context is important. And just a little bit about placebo. Now, you may have heard about placebo. Placebo is a term we use for a medication which has no active ingredient in it. And of course, you believe that people, of course, you've heard people respond to placebo, but they are the feeble, the weak, the dim-witted, and the weak of character, unlike yourself. To say that, however, the ability to learn from experience and expectation is hardwired in us. And let's go through this experiment. This is another very similar test, and the test involves not cold water, but simply you put a tourniquet on the arm, cut the blood supply off, and then you ask the person to exercise. And after a few minutes, it cramps and it hurts. And you just, with a stopwatch, see how long does it take for a person who says, I can't do this anymore. You have a pain rating scale on 0 to 10, and here's time. Now, the blue line is a group of volunteers who had no treatment, and as you can see, after 8 minutes, most of them said it hurt quite a lot. In the same experiment, they were given a powerful painkiller. But that red line, the way it was done is that the doctor would come in the front, you are now receiving the powerful painkiller. And the experiment was repeated, and as you saw, the drug worked extremely well. But in the same experiment, they gave the same drug without the person being able to see it. It was in the IV tubing, but behind them. So the ketorolac was given same dose, but the person didn't know when it had been given. And it still worked. That's the light blue line. And so what's the difference between that light blue line and the red line? It's the drug is the same. The context was different. The intriguing bit is about introducing the pharmacology of placebo. Placebo is a drug. And so in this red line, what actually happened was, again, the doctor came out the front. I'm now giving you your powerful painkiller. But previously, the people had been given an antidote to morphine. And that your expectation can turn on your own, the production of morphine-like peptides in the brain. And so, in the presence of the blocker, you got rid of the placebo response. So you can see the real drug effect is this one, but the drug in the presence of the anticipation is much better. Now, is that good or bad? Should we mislead our patients? If I looked my patients in the eye and said, I'm just the best doctor, I'm going to fix you, my drugs are the best of anybody, I might get in the short term a placebo response. But of course we don't actually do that because it's dishonest, it's not truthful, and then people will lose confidence and faith. But we can't eliminate the placebo response. And it's why in clinical research we always have to use a placebo limb, because I can assure I've seen Lazarus-like responses in clinical trials to people who've received placebo. And they can't believe it, and they say you've got the code wrong or so forth. And this is not because they're feeble or weak-willed. This is hardwired biology, and we have to recognise that it does occur. Now, last time in this introduction, we introduced the concept of neuropathic pain. This is pain not due to irritation of the peripheral tissues, but irritation of the nerves themselves. And this is a particularly problematic type of pain to deal with. This is one of the common forms is shingles. Shingles is a viral infection of the nerves. You initially get a bit of a rash, that settles down. It's often on the trunk, as in here, but people are left with severe pain, often in the area of the rash. And it has very characteristic symptoms. There's a resting tingling or burning. But something has gone wrong with the information processing. Things that weren't painful beforehand are now painful. Patients will say, I can't bear clothing, even a light shirt on there. A cool breeze on my side will now be painful. Now this can't be due to activation of those pain fibres. A light breeze doesn't do that. Something has to have gone wrong with the pain processing in the brain and spinal cord. So again, this is not straightforward. Now to summarise, I can't put all the research in detail in here, but we're now seeing that chronic pain, as we illustrated in the post-traumatic neuralgia, it's a result of adaptive changes in the brain and spinal cord. And recently, work mainly in the UK, has shown that we can now see this on brain scanning. We can see the brain reorganise. That in chronic pain, we can see parts of the brain, some increase and some decrease. And in some studies, those are reversible with treatment. So it's not a simple system, it's a dynamic, adaptive system. So that's a little bit of run to show the complexity of pain. But of course, what we want to do is do something about it. How can we prevent or treat chronic pain? Well, the obvious thing is if we can remove the underlying cause, well, that's straightforward. We learn that as children. And when there's tissue inflammation, such as in rheumatoid arthritis, a very painful condition, we're now very good at treating that inflammation, and the pain with that is generally quite well controlled for a lot of people. But in conditions like neuropathic pain, where there's this wiring disconnect, we can't really remove that cause, and that's a very difficult condition to be able to treat. You might think, well, why don't we just cut the circuit? You know, I've shown that the pain signals go through the peripheral nerves. Why don't we just stop it? And you've probably all experienced that when you go to the dentist, before they do something which would be quite painful, puts a jab onto your nerve, you get completely blocked. So they can drill away, it doesn't hurt at all. Of course, doesn't give you normal sensation, does it? It's a horrible feeling at you when you're at the dentist. It's a dull, thick feeling. So you wouldn't want to have that all your life, but it's very nice for that little bit of time. So but in people who have localised pain, why don't we just cut it? I'll give you an example. Here's one headache condition I do. It's a rare condition called cluster headache, a condition generally seen in middle-aged men, and it has excruciatingly severe pain in attacks that occurs directly behind just one eye. Although there is treatment for this that doesn't work in everybody, and the major complication of this condition untreated is suicide. It's an extremely painful condition. But it's so localised, the patients don't say the pain is here, they say it is here. I want you to pluck my eye out. Think, well, why don't we just interrupt the pain pathway? Because not only is there only one nerve to the side of the face, there's only one branch that goes up there. We could make that area numb by just cutting that one branch. So doctors a while ago tried that. And unfortunately, the results were, what was guaranteed was the person would get numbness. You've cut the nerve. But the pain didn't necessarily go away. And people had the worst outcome. You end up with no feeling, but pain. You think, how can that occur? But it does. Similarly, in the Korean War, American military doctors, they'd see some people with blast injuries, paraplegics, and although paraplegics have no feeling below the level of the lesion, there's often a lot of pain at the level of the lesion. And there was severe pain not responding to opioids. And the doctors thought, look, the guy's already paralysed. We've got to do something about their pain. And they actually, this radical idea, they actually removed some of the spinal cord above it. So they're already paralysed, they can't do any worse. But I'll do a complete disconnect of the nervous system between the top half of their body and the bottom half of their body. Didn't get rid of the pain. So again, it tells us that it's not simple. So surgery for pain, for nerve surgery, is done rarely and only in selected cases. What about drugs? Well, I'm a pharmacologist. Drugs are our business. And of course, you go to the pharmacy, there is a huge array of medicines there behind you. If you put them all there, you wouldn't be able to see any individual images. The problem, despite there being many, many medicines, the number of unique active ingredients is actually relatively small. And when you break it down to drugs that work in similar mechanism, we've really only got very few classes of unique active ingredients. And there they are: paracetamol, aspirin and aspirin-like drugs, morphine and morphine-like drugs, some anti-epileptic drugs, some antidepressant drugs, and a few specialised ones. And that's largely it. So how good are we at all this? Well, paracetamol, well, it's a familiar drug. Despite it, we actually still don't know how it works and how we might be able to make it better. With aspirin and the aspirin-like drugs, we know how they work, but we also know they cause a lot of long-term side effects. And so nowadays, apart from low-dose aspirin for cardiovascular disease, well, this class of drugs we now generally recommend people should take at the lowest dose for the shortest possible time, because it can cause ulcers, high blood pressure, heart disease, kidney problems, etc. So we try to avoid those. Then there are the morphine-like drugs. As I mentioned, these have been around for a long time. It'd be hard to imagine the practice of medicine without these. It's a sort of a miracle. Working casualty, a person comes with a broken leg in severe distress. Within a few minutes, you can get those people somewhat comfortable. Where the morphine-like drugs work, they largely work on the emotional parts of the brain. And patients will tell you, it's not that the pain goes away, but it doesn't distress me as much. So they're essential now for modern surgical practice. But surprisingly, they work disappointingly in chronic pain. And I'll come back a little later on as to one of the reasons we think why they are rather disappointing in chronic pain. And although they're not very effective, what we do know is we're getting more and more evidence of the harms, and unfortunately this is getting to be a major public health problem in Australia and other developed countries. This is an editorial from the New England Journal of Medicine, one of the world's sort of most prestigious medical journals, and these normally have very sober, unemotional, very factual kind of wording. It's quite uncommon to see a medical journal with the titles with wording like a flood of opioids, a rising tide of deaths, epidemic of drug abuse and overdose deaths, indicating this is a serious problem. Here are some words about pain management. And I've covered up where this all comes from so we can have a look at it. It starts off saying, I believe there are 5 preeminent crises in pain management today. To paraphrase the first one, it says, we don't know what works. Number 2, we haven't trained GPs. Number 3, we don't know whether the drugs we've had for 3,000 years work or not. And number 4 and number 5 is we haven't got enough resources to treat it. Where does this come from? Some underfunded backwater, some developing country or so forth. And when was it said? Well, it comes from the International Association for the Study of Pain, from one of the world's top academic medical centres. And the depressing part is it was written last year. Now, I don't want to be too downbeat. We're coming here, hopefully, get some positive news. But let's just finish at this bit. So, summarise this point, pain is hard. It's not useful when it persists. We're not particularly good yet at treating it. And one of the mysteries is why one patient can have horrendous injuries and but recover without chronic pain, and others may go with a much smaller injury and may go on to chronic pain. Where could we look for new insights and new approaches to treating it? And that is what our team has been looking at. The area we're mainly concentrating on is the body's other danger detecting system, and that is the immune system. The immune system is what detects and fights off infection, viruses, germs and so forth. The brain has its own immune system, and we've been asking, what is the role of this in pain? There are cells, part of the brain immune cell come from cells called glia. It comes from the Latin word for glue, the Greek word for glue, because it was thought they just sort of stuck the nerve cells up there. But recent research has shown that these produce chemicals which can make the nerve cells more sensitive to pain. So we've been asking, do they have a role in pain? Now, to put a whole lot of experiments into one hypothesis, our working hypothesis to explain why some people get pain under certain circumstances is that chronic pain is a result of a fertile soil of a certain genetic predisposition, then a priming event which alerts the system that more danger may be on the way, and then a sequence of activating events which keeps the system sensitive. And it's probably only likely that chronic pain occurs when all of these factors are occurring. But how do we test this prospectively? Now, this is what I think is a key animal experiment, and I'll take you through a little bit what it is. It's in rats where we have experimentally given them a form of sciatica. And we can do it so it's either mild, moderate, or more severe sciatica. The way we measure it, and I'll show you that we have these, I know medical scientists like to impress you with how high-tech their equipment is. Well, I've got a foam paintbrush from Bunnings, and I have some plastic on a stick. And these are scientific grade plastic on a stick. But basically, it just pokes, and we can measure how hard it pokes. And with the rats, we have soft ones and gentle ones, and we just measure how much stimulation we need to give their foot before it draws its foot away. The more pain the animal is, the more sensitive to being gently poked. So on this axis, this is how stiff the little rod is before the rat pulls its foot away. This is stiff, this is fairly gentle. So the lower here, the more pain the animal is in. And what we have done in this experiment is to see whether we can transplant the pain state from one animal to another. What we've done is we've taken immune cells from the spinal cord from one group of rats and put them into another. Now, if we put cells into a no-pain rat, nothing happens. If we take a low-pain rat, however, and give them cells from a no-pain rat, nothing happens. Those are these curves up here. But if we take cells from a high pain rat and put them into a low pain rat, we have turned them long term into a high pain rat. So we have transplanted the pain state, not by an injury, but by taking immune cells from the spinal cord. So we think there's a key experiment demonstrating the pivotal role in the immune system in pain, but also the key thing is if we put these high pain cells into no pain animals, they didn't become high pain. So we needed the fertile soil of the priming event, the low pain animals, and then the extra stimulus. So it's only when those two factors occurred did we see the transfer. And this was both on the operated side and the non-operated side. So we think this is a very important experiment. You can't possibly imagine how you could do such an experiment in humans. So we've had to think, how can we test the same kind of idea safely and ethically and sensibly in people? And this is a study that was done by a medical student visiting us from Holland last year, which we're just publishing, and we think demonstrates this hypothesis, and we think this is the first demonstration in humans of a link between the immune system and the pain system. The pain that we did was we injected capsaicin, which is the hot ingredient of chilies, into the skin. Now, any of you who've been working in the kitchen and have not washed your hands properly and have brushed your eye or gone to the toilet will know that capsaicin is quite irritant. It stings and it burns. When we inject it into the skin, it hurts a bit, and that's the bit we measure. We ask people how they feel. There's also a little bit of redness, called flare, but also in the area around it, you are sensitive, and that's where we use 29-cent foam paintbrush from Bunnings, and this obviously doesn't cause any pain, but after you've had a capsaicin injection, there'll be a point which this is no longer pleasant, it's now ouch. And we can measure the area that becomes sensitive, and we can also go and say, this is fine, oh, now it hurts. And this is a transient response which lasts about an hour or so forth, and it's safe. So this dotted line is what happens to people for a little while. They get, when we stroke them, they're sensitive, when we poke them, they're sensitive, they report pain, and there's a little bit of redness. But then we gave a subtle immune stimulant, and we used endotoxin. Now, of course, anything with the word toxin in the name is obviously not a very nice substance. It's actually a fragment of, a non-infectious fragment of bacteria, and it's the thing that's responsible for giving you a raised fever in infection. Humans are extremely sensitive to this, and we gave a few billionths of a gram intravenously. This is safe to do. It causes no symptoms. And then we then did the stroke, poke, ask and red tests on volunteers after this subtle immune stimulus. And you can see there were huge increases in the pain sensitivity. So the first time we've demonstrated that we can now turn on the immune system to make it more sensitive in pain in humans. And what's exciting about this is we can now test drugs with this. See, how can we modulate? How can we test it? We say, do different people, do they vary? Are they sensitive? So that we believe we're going to get a lot of information out of this model. Now, remember earlier on I showed that women were more sensitive to pain. We've been hypothesizing that the female hormones may be turning on those immune cells and make them more sensitive. One of our PhD students has been testing this. Now, how these little three-dimensional graphs work, on the height axis, it's how much an animal responds to the stimulus. These numbers along here are how stiff the hairs are from light to hard. So these plastic rods, the stiffer ones cause more pain. And this is in our sciatica groups. It ranges from relatively low pain animals to the higher pain animals. And you can see in the male rats, they really only get a pain response in the high pain group with the hardest poking. On the other hand, the females are more sensitive. They get a bigger response and to gentler stimulus, and even in smaller groups. So we've confirmed that females are more sensitive. You think, well, so what? That on its own is not great shakes. Then, in the female group, we looked to see what happened in the different phases of the rat cycle, whether it was a high estrogen part of the cycle or a low estrogen part of the cycle. And that's this set of graphs here. And you can see that almost all of the exaggerated response in female rats was in the high estrogenic phase of the cycle. We also looked to see whether the phase of the cycle determined on the day of testing was important. And again, we could see that this was a response. So it strongly seemed that the estrogenic phase of the cycle was affecting the pain response. We've recently looked at the similar transplant experiments that I showed you earlier on, and I haven't even got a slide of this because the experiment was really only done last week. And we took spinal cord immune cells from female rats and put them into male rats. And they developed the pain profile of the female rats. Again, this confirms to us that this is a likely pathway of the gender-determined increase in pain sensitivity. I mentioned earlier on, I said that the morphine-like drugs are quite disappointing in chronic pain. And it's actually one of my colleagues, who's here, Mark Hutchinson, the idea which we've been working on is how could these medications sometimes be making people worse? Now, if we look at it, here's a nerve cell, a pain cell for nerve, a nerve cell for pain, and in the presence of a strong painkiller, typically that will calm down that nerve cell and the person gets less pain. But what Mark's discovered is that these immune cells, they don't get calmed down by morphine-like drugs. Unfortunately, just by chance, it seems to activate their danger-detecting signals. And so they recognise that as a dangerous signal and turn on the brain cells, and it produces more pain. This is a bit of a vicious cycle because the drug may acutely help pain but turn it on. But of course, it gives us an opportunity that we could look at new treatments by trying to break this process. And so we've been targeting this system here to see whether this is a new treatment opportunity to break the turning on of the pain system by the drugs we give, which are meant to help patients. Now, there's one pain condition where we've actually got very strong evidence that painkillers make the problem actually worse. And this is medication overuse headache, mainly associated with codeine-containing painkillers. Those of us in headache practice, we see many, many patients say, I've got a headache all day, every day, I'm taking painkillers every day. You think, well, of course, they've got pain every day, they're taking painkillers every day. But when you talk to them in detail, they didn't start that way. They started some time ago, they only used to have intermittent headache. They took painkillers and gradually things just got worse and worse. Which is the chicken and which is the egg? And there's a lot of evidence that it may be the drugs that are actually making this worse. One demonstration of that is from looking at what happens to headache in people who've been given painkillers for other conditions. And in patients who've had arthritis and they also happen to have had some headache, if you give them regular intake of strong painkillers, they get worse headache. But if you take arthritis patients who don't have much pre-existing headache, you give them the same medications, and they don't go on to get worse. So we've hypothesized that the codeine in these painkillers is activating the glial system and making pain worse. Now, at the moment, how do we manage these patients? You think, well, it's easy, stop taking the medications. The problem is that once you stop it fairly acutely, the benefit disappears very quickly, but the sensitivity is already there. And in the short term, people are much worse. So it's quite difficult to do. So what we want to try and do is see, can we calm this system down and act as and help our patients? And so we've published this hypothesis. One of my PhD students is here, Jessica Johnson, has been running this trial where we're using a drug which is targeted at calming down glia to treat medication overuse headache. That trial's currently in progress. Now, in the rats, we could access the brain and the spinal cord immune cells. We clearly can't do that in humans. But there is obviously a very good immune system in the blood. So another one of our projects has been looking to see, can we learn anything from blood cells that we can access, or immune cells that we can access in people? So another one of my PhD students, Haley, we've taken blood start off from 3 groups of people: healthy people with no pain, people with chronic pain, and also people with chronic pain who are on morphine-like drugs. And we just took a blood sample and in the test tube added an immune stimulant to see how sensitive were those cells, how turned on were they. We just measured the response. And you can see there's a huge separation, that the people with chronic pain had a much better response. And as we hypothesized, people who are on opioids had an even stronger response. I think that tells us 2 things. One is that it gives us further evidence in humans that the immune system is involved in chronic pain. But it gives us the potential, this could be a diagnostic, a blood test for pain, which could be used for diagnosis, stratification for clinical trials, monitoring response to treatment, and that work is currently underway. Of course, the best strategy is to prevent pain rather than treat it, and we are currently also doing another study using a different glial inhibitor. It's an antibiotic, but this particular drug in the animal studies only seems to work when it's given before the injury. Now, you can do that in an animal study, but it's very hard to know when is a person about to get hurt. But there is one situation when people are about to get hurt, and that's when they're about to go to have surgery. And there is one type of surgery, chest surgery, where there's a very high rate of damage to the nerves. And obviously, I think, well, because it's done for serious disease and the operations need to be done. So we're currently doing this study where we are pre-treating people with this antibiotic, which may calm down the glial activity to see whether it prevents chronic pain. And we've just won some internationally competitive funding to look at a similar approach in migraine, and that'll be starting at about the middle of this year. But although I'm a pharmacologist, which means that you know about drugs, I'm a pain clinician, I want anything that will help my patients. It doesn't just have to be medicines. And there is increasing interest in electrical and magnetic approaches to control pain. Now, you may have heard of one treatment, transcutaneous electrical nerve stimulation, or TENS, and this was developed by the guys who initially thought of that gate. Remember I mentioned show you that local control, and they actually called it the gate theory. And they said if we can actually increase the activity of the non-pain detecting fibres, we might be able to tone down the sensitivity. So TENS is a way of giving a little electrical tickle along the nerves along the back, and it's safe and it has some effectiveness. The problem is that for you to know what works and what doesn't work. For a drug to be licensed, it has to be shown not only to be safe, but it also has to be shown to be effective. But through to a different regulatory system, devices only need to be safe. They don't need to be shown to work. So there are some things out there that might work, and there are some that are just taking your money. So let me show you something that actually might work. Unfortunately, I couldn't get a bigger image of this. It sounds like a really bizarre device. This is giving a blast of electromagnetic energy to the back of the head at the beginning of a migraine attack. The thing's big, it's got a big battery, it's like a hard back, and you basically zap the back of your head at the start of a migraine. And surprisingly, it seems completely safe. And it also seems to be effective. This is not yet available in Australia, but this looks as though it may be a useful treatment. Let me show you the kind of thing to watch out for. The first hint is, as seen on Dragon's Den, is probably not the best place that you would expect to see authoritative medical information. And when you see the claims, you know, drug-free, no side effects and so forth, these should start your alarm bells going. Made by a French company, and I think there'd be more effort gone into the tiara-like design than to the evidence. And they really can produce they say clinically tested, which is true. They showed it's safe. That's not the question you want to know. The question is, does it work? They won't answer you that. But we're currently doing a study of electrical brain stimulation in headache using a very simple and safe technique, using an electrode, a little bit like one of those dictation headsets, and that trial is currently underway. We expect that to have a very safe outcome. We don't know how effective it'll be. So that's by a bit of a run through of some of the work that we're doing. As Mike mentioned, we have a dedicated clinic that runs these clinical trials. Some of you may know people with a number of pain conditions. They can always have a look at what we're doing, seeing whether there are trials that may be suitable, and some of my students will be outside if you wanted some information or be kept informed what we're doing. We'd be only too happy to give you further information. I keep mentioning we because it is a team. My colleague Mark is a very talented scientist and has been key in developing the experimental theories and the ideas of both the animal studies and the clinical studies that we've done. And thanks to a number of my former and current PhD students as well as medical students who have contributed to the work. Thank you for your attention.